years is Hospital Saint-Justin in Montreal. His expertise is really in B-cell reconstitution after bone marrow transplantation, and this is the topic of his talk. Elie.
So good afternoon. I'm going to speak about the reconstitution of humoral immunity after transplantation for SCID patients. These are my conflict of interest, and there will be three parts. The first part will be, is it important to consider the B-cell reconstitution after transplantation in SCID? The second, I will try to review what we know about the kinetics of B-cell reconstitution. And then I will end with the third part that will describe which factors can influence the B-cell reconstitution if we say that it is important. So finally, who cares? The SCID patient should die. We transplant him because he has no T cells, and we cure the T cells. So what is the problem with B cells? We don't care, correct? We just want to cure the T cells. But if we look at the big picture of the transplantation in SCID, in this paper from January, that is the European cohort from 1968, we see how it works. We do pretty good with a related identical transplantation, with unrelated donor, related partially identical, and mismatch related. And if we focus on the last decade, well, it's much better. So looking at this, we say, come on, the results are quite good, so maybe if there is a problem with B-cell reconstitution, who cares? Actually, there is a problem with the B-cell reconstitution, and we can see here that it's true that it's a little bit different between the B-minus SCID and the B-positive SCID, but there is something like 60% of the patients who are off IVIG. And if we look at the cohort, the retrospective review of the literature that we did when we published the paper with Becky Buckley in JACI, we found that some patients, something like 20-something% of the patients, up to 40% of the patients, still need IVIG when we say that they are cured. So there are many patients who are under IVIG. So it's true that it's less important than T-cell function, and there is a link between the reconstitution of the T-cell function and the B-cell function. Nevertheless, I'm going to try to prove you that it is important. And the question is it a real issue that a SCID cure patient is still under IVIG? The first lesson, I think, comes from the Wiskott-Aldrich. In the Wiskott-Aldrich setting, when there is a transplantation and there is a donor engraftment of T cells, but there is a recipient B cells, then there is an autoimmunity because intrinsically the B cells are sick. They are prone to do autoimmunity and to have autologous clones. And when they are stimulated by normal donor T cells, then the autoimmunity can be very severe. So it's better to have a full reconstitution in Wiskott. Also, our patients with common variable immunodeficiency, if we think that curing a SCID patient without curing the B cell is okay, then why do we take care of CVID? In most of the cases, it's a B-cell deficiency. And we see that in those patients, if those who don't have autoimmunity or inflammatory complications do quite well, but as Charlotte mentioned, and many people published, like Helen Chappell or Klaus Schwartz, when there is an autoimmunity, it's a mess, and those patients are very sick. So do we have the same problem in SCID after transplantation? And the lesson from the literature, I think the best paper to address this question is the paper published by Benedict Neven in Blood, the Paris cohort. And interestingly, they looked at the evolution by separating the patients with those who are under IVIG in black and those who are not under IVIG in gray. And if they look at the event-free survival, the difference is very impressive. If they look at the frequency of all events apart from severe HPV infections, and they do this because HPV infection is a true problem for JAK3 and gamma-C SCID, there is also a huge difference, meaning that if you need IVIG, you do poorly. Then, if they look at all the infections, the HPV, the autoimmunity, the inflammation, the need for natural support, and the chronic graft versus host disease, also there is a significant difference. And the same for the infection if they include or if they don't include the HPV. So if you look at this slide, you say, okay, IG reconstitution, so B-cell reconstitution is absolutely crucial in SCID, and when they don't have this B-cell reconstitution, they don't do well. Yes, but it's more complicated than that is, because it's the same for the T-cell reconstitution. It's exactly the same picture. When there is not a good T-cell reconstitution, then you have the same problems. And one could say, well, the B-cell reconstitution is just a problem of T-cell reconstitution. So you just take care of the T-cell reconstitution, and things are going to be all right. Maybe, maybe not. Let's go away from the SCID, and let's see what the literature tells us about the non-SCID patients. And I found this manuscript just published in 2008 in bone marrow transplantation, in which they just looked at the survival after transplantation in 170-something patients. It's leukemia, myelodysplasia, and everything, and some primary immunodeficiency, actually. And the patients who have normal IgG before 1 year after transplantation, and when they compare with those who have low IgG, in this manuscript is below 400 milligram per deciliter, there is a difference in survival and also in transplant-related mortality, meaning that by itself it's a factor of prognosis after transplantation. And if you look at if you read the first sentence of the abstract of this paper that I like, it's written, manifestations of cGVHD can resemble those seen in immunodeficiency states and autoimmune disorders. Meaning that the idea that is coming up from the literature is that patients with chronic GVHD look like CVID-like patients. They have some hypogam, they have autoimmunity, they have autoinflammation, and they do very poorly. And this author, they found that the patients with hypogam post-transplantation, they have less B cells, increased CD19 plus CD21 low, increased CD19 plus CD21 intermediate and CD38 high, and less switch memory B cell. Doesn't it recall you something? It's exactly the phenotype of the CVID patients with the autoimmune complications. And the way it's written, it says that GVHD can induce B cell dysfunction, but at the same time, B cell dysfunction is a factor of risk for GVHD. So it's the question of the egg or the chicken. Who is the first one? We don't know, but it comes together. And an abnormal B cell function is not a good thing. So we should try to do the best to have a normal B cell function after transplantation. What do we know about the kinetics of B cell reconstitution after transplantation for SCID? It has already been shown some years ago that B cell reconstitution takes a little bit more time than T cell reconstitution. It comes after. And usually it takes 1 to 2 years after transplantation, when we reviewed 117 patients in blood in 1998. And Rebecca Buckley and Andor published that it took more than 2 years. So it takes 1 to 2 years. And also it was shown that, as we can think, B cell function depends on T cell function. And this is the manuscript we published in 1998, showing the evolution of the T cell function and the evolution of the B cell function, with a definition here, but the in black is the normal T cells and the other are T low or T negative. And what you see, what I wanted to focus is that even if you have a normal T cell function here, there is a difference with the number of patients who have a normal B cell function. Meaning that it is not automatic that when you have a normal T cell function, then you have a normal B cell function. There can be a discrepancy between the two populations. And also here we showed that it's not the same if you take the B plus SCID patient and the B minus SCID patient. And the reason is simple, because in B minus SCID patients, if there is no B cell engraftment, there is no chance that there is a B cell function. While in the B plus SCID patients, there may be some B cell function. I took also this paper that has been published in PLOS ONE in 2012 by the team of Raz Shomer that was published, the team of Raz Shomer from Tel HaShomer in Tel Aviv. It's very interesting. It's about 10 patients that have RAG2 deficiency and who have been transplanted who have been transplanted. They could find 4 patients in which they analyzed the cracks, so the rearrangement of the B cell receptor, and they found that 4 patients had normal crack between 2 and 6 months post bone marrow transplantation. When they looked at the signal joint or the coding joint of those cracks, they found out, here are the control, they found that in the control you have more coding joints, meaning that the B cells are proliferating, while doing this, they can distinguish between the B cells emerging from the marrow from the B cells that are replicating. And they found that in those patients, it's newly formed B cells. Okay. They found also, and that's interesting, they could not do statistics because it's only 10 patients. But all the patients who did well were those patients. The 3 who are here, who had no crack at 6 months, died, and some who had low crack that came progressively had severe chronic graft versus host disease, making a link between the rapidity of the B cell reconstitution that can be seen as soon as 4 months post-transplantation with the evolution of the patients. It's only 10 patients, but it's interesting. And here also, they show that by doing a spectra typing, even if they can find, it's focused on one patient, the patient 7 actually, even if they can find that there is crack in these patients at 6 months post-BMT, the spectra typing is oligoclonal, and it takes much more time for it to become polyclonal. And at the same time, there is a proliferation of the clotting joint, meaning that there is a proliferation of the B cells. So it's a nice study that shows that the B cell reconstitution begins earlier than when we thought, and maybe it's also a factor of prognosis. So since it's a factor of prognosis, or I believe it is, what is important in the bone marrow transplantation to induce a better B cell reconstitution? To do this, with Becky Buckley, we did a review of the literature, and we looked at all the manuscripts that have been published on B cell reconstitution, and we addressed the question of the B cell reconstitution as a function of conditioning regimen and as a function of engraftment of B cells after transplantation. And first of all, we separated in all the papers the patients who were transplanted by an HLA identical donor, because in most cases there was no conditioning regimen there. And then we separated those who had no conditioning regimen with those who received the conditioning regimen. With something to mention is that we grouped together no conditioning regimen or just an immunosuppressive conditioning regimen. While here we put all the containing busulfan, meaning myeloablative conditioning regimen. And if you do the addition of all those small numbers, there is 2 total, the total 1 and total 2. Why? Because the 2 biggest papers, that are the one from Becky Buckley here, we couldn't take out the data because there was a mix between the HLA identical and the HLA non-identical, so we couldn't have the numbers. And in my paper that I published in 1999, actually, I could only find the paper in my notes, and I did not publish it. So you cannot believe me, because I was not reviewed for this. So let's take away those two studies, and let's just do the total 1 without those ones. And there is a big difference between the no conditioning regimen and the conditioning regimen with a normal B cell function that was defined as being off immunoglobulin that is much higher in this group. So it's better to have a conditioning regimen. If you do the total, if you take all the patients that have been published, you have exactly the same conclusion, so it doesn't change anything. But, well, it's not a proof because it's not an analysis that has been designed to prove this objective. It's just a kind of meta-analysis, and we go in the papers and we take all the numbers. So it's not a scientific proof, just a trend. So now we looked at the chimerism of B cells, and in each paper we find how many donors, how many recipients, and sometimes they gave the percentage. And in some paper, for example, they say there is traces. When there is traces of B cells, I decide to put them on the recipient. While when they say that it was mixed, I said, okay, there is some donor B cells. Doing this, we see here that the more you have B cell engraftment, the more you have a B cell function. And in the patients without conditioning regimen, there is more patients without B cell engraftment, while when there is a conditioning regimen, there is more B cell engraftment. And when there is more B cell engraftment, there is more B cell function. So that's quite simple, quite logical. And the message is that we should do a conditioning regimen if we want to have a normal B cell function. It's more likely. We also looked at if it was true in the HLA identical BMT setting, and most of the cases are not conditional. Some did, and actually it shows the same, that in this case most of the patients are not conditioned, and something like 60% of the patients have a normal B cell function. Another thing that I found in those manuscripts, like in all the papers where the B cell function was very impressive, very good, they almost all receive Bu16. That is a high dose of busulfan that usually most of the transplanters don't use for a SCID patient because they are afraid of hurting the patients with this kind of dose. And also in the study of Slater, in the same manuscript, they found that the 13 patients with Bu16 were all off IVIG, while the 21 patients with Bu18 were not all off IVIG. So maybe the more you give, the better it is. So I gave a phone call to Benedict Neven, and I asked her, do you have data in your paper that you didn't show that maybe I have to work on this? Do you have something that shows that conditioning is better? And she gave me those data. I thank her. And if we look at the immune reconstitution, B-cell immune reconstitution at 2 years, in no drugs is the level 1 for the statistical value. You see that having high BU is the best thing to have in order to have a good B-cell function at 2 years. And if you see the immune reconstitution at the last visit, the thing that is statistically significant is again the high BU dose. So giving more busulfan induces more B-cell function because of more B-cell engraftment. And if she looks at the multivariate, in a multivariate modeling, what is going to determine the B-cell function at the end of the follow-up? First of all, of course, the IVIG at 2 years, meaning that when you are under IVIG at 2 years, you are at risk of being for all your life at IVIG, of course, and also the busulfan. So saying this, we could say, okay, we should give busulfan to all the patients. But, there is a but, Becky Buckley doesn't completely agree with this. And why doesn't she agree? Actually, she agrees on this data, but she says, you know what, there are also SCID, and there are also patients that you don't need to condition. Is it true? Yes. In our data, we saw that there were some patients that even if you don't do a conditioning regimen, there is some B-cell engraftment, and also in those who don't have B-cell engraftment, there is sometimes some B-cell function. And to show her point, she published 125 patients, no ablation at all, no conditioning regimens, and she studied the B-cell function depending on the molecular deficit. And what she found is interesting because if there is a gamma C, so all those patients, since there is no conditioning regimen, most of those patients have B cells from the recipient. Okay, so it's a good way to analyze how they function because now they have normal T cells together to make them work. And the gamma C or JAK-TRA B cells don't work very well. Most of them are under IVIG, and they do respond poorly to the phage. They don't have a high percentage of memory B cells. They do respond poorly in vitro to IL-21, and that's logical because it's gamma-C dependent, while they do respond well to IL-4, and it's not gamma-C or JAK3 dependent. And for BAF and B-cell repertoire, it's normal. While for the IL-10 receptor alpha, ADA deficiency, and CD3 deficiency, actually there is no B-cell problem here, and they are completely normal, meaning that you could have complete normal B cells without having a B-cell engraftment. And that may explain why it's so difficult to analyze the literature, because we put all the things together while it's not all the same disease. So what are my conclusions? I would say that obtaining a normal B-cell function should be one of the major objectives of HHCT in SCID patients. It's true that conditioning regimen does not guarantee B-cell engraftment or normal B-cell function, and that you can have normal B-cell function without conditioning regimen. However, conditioning regimen is better than no conditioning regimen for B-cell engraftment and for B-cell function. In the absence of B-cell chimerism, the molecular deficit has a role, and in some diseases it can work well, while in gamma-C and JAK3, and also, of course, in the amoeba in the SCID, like Artemis or RAG, you absolutely need a B-cell engraftment. So the question becomes, if we have to do a conditioning regimen, why don't we do a conditioning regimen? Because there is a risk that comes with it. A risk maybe of GVHD, of T-cell reconstitution? No, the T-cell reconstitution is sometimes better when there is a conditioning. Toxicity, that's the point, maybe. And it's not sure that the toxicity is the same for all type of SCID. So what do we need now? Now we need retrospective studies that address specific questions. And the question is not, should we do conditioning regimen in SCID? No. Should we do conditioning regimen in this type of SCID? And which conditioning regimen should we do? And that's the reason why we need a huge number of patients in order to cut the groups and to do the correct analysis. Also, for the SCID with DNA repair defect, they don't have B cells, and we want them to have B cells. So we have to do a conditioning regimen. But since they have a DNA repair defect, it may be dangerous. So there is a room to find new tools to induce an engraftment without giving conditioning regimen like anti-c-KIT antibody, like stem cell mobilization, or what you want, what that works. There is also the new question that is being addressed by the neonatal screening. Okay, we want to have a B-cell engraftment, meaning that we want to do a conditioning regimen. But more and more, and particularly in North America and in USA now, we are going to transplant younger patients. And those younger patients, what is published, even if you don't make a conditioning regimen, the survival is 95%. So is it worth it to take a risk and to give a conditioning regimen just to have a B-cell function in some years? We could say yes, we could say no. And all the doctors don't agree together. Should we or should we not give a conditioning regimen to a neonatal born screened patient? And I would add that in general, there is very few literature on B-cell function after HHCT, and more and more patients are described like being CVID-like, even in the SCID population. And maybe there is room here to do some interesting study and to have much more patients to analyze. So I thank you for your attention, and I would like to thank Becky Buckley. It was a pleasure to work with her, Sandrine Leroy and Benedict Neven, who helped me and who shared their data with me. Thank you.
Maybe one quick question. You mentioned in your last slide some novel strategies to achieve engraftment of donor cells, which are not based on chemotherapy. You mentioned mobilizing the recipient stem cells or perhaps using anti-c-KIT antibodies. But for B-cell reconstitution, perhaps the other thing one has to consider is that there are bone marrow niches also for B-cell progenitors in the marrow. It's not just a matter of the stem cells, because many of those disorders do allow some B-cell differentiation up to a certain stage. And so you also have all of those niches occupied. Any thoughts how we could, get rid of them?
I do completely agree with your remark. It's true that if the niches are occupied, maybe you absolutely need to kill the cells that are in the niches to make some room. I don't know. Is it true, this theory, that we absolutely need some room? There is the experiments with the c-KIT antibody in the mice. It's true. It's very elegant because they show that when they take away the stem cells from the niche, then there is a competition between the donor and the recipient cells, and there is not an advantage for the recipient. It's like a 50-50 thing, meaning that when you put them away from the niche, then it's like if you had killed them somehow. So I like the idea of the c-KIT, to tell you the truth. I find it very elegant, and I hope it will prove that this theory of the niche maybe is not that true. But you're right, it's a thing to consider. You're perfectly right. Thank you.